Plotzker. Good afternoon, everybody. My name is Dr. Rosalyn Plotzker. We'll be getting started in just a minute. Just to make sure you're in the right place, this is the STD clinical update for congenital syphilis for California jail providers. And we'll be starting in just 1 minute. Good afternoon for those who are just coming in. This is STD clinical update on congenital syphilis for California jail providers. I'll be getting started in just a moment. Some people are still trickling in, but we'll be starting soon. And thank you for joining us. Okay, good afternoon, everybody, and thank you for joining us. For those of you who are just coming into the room, my name is Dr. Rosalyn Plotzker, and this is an STD clinical update from the California Prevention Training Center. Today, we'll be talking about congenital syphilis for California jail providers, and I am honored to be joined by Clara Kovaleski from the California Department of Health and Dr. Kristin Walsh. So let's get started. Clara Kovaleski is the former acting section chief of the Health Promotion and Healthcare Quality Improvement for the California Department of Public Health STD Control Branch. She has been with the STD Control Branch since 2011. And of note, she is the co-author of the expanded syphilis screening recommendations for the Prevention of Congenital Syphilis guidelines for California medical providers. So we are honored to have her here on this call. I'm Dr. Rosalyn Plotzker. I'm an assistant professor at UCSF in the Department of Epidemiology and Biostatistics. I completed a fellowship in STDs with the California Prevention Training Center as well as CDPH. And now I'm the Public Health Medical Officer for the STD Control Branch. And in addition to that, I'm also clinical faculty for the California Prevention Training Center. And finally, Dr. Kristin Walsh is an internist and HIV specialist with the Santa Clara County's Adult Custody Health Services, where she has served since completing her HIV Corrections Fellowship at the University of Southern California, and that was in 2015. She coordinates the STI screening program and the HIV and Hep C treatment programs for the Santa Clara County Jail. And she's going to give us some on-the-ground experience to accompany the lecture. So a little bit about the California Prevention Training Center before we get started. We are a multidisciplinary training and capacity building assistance center. This is our logo, the CAPTC. In case you see it around, you might recognize it. We're funded by the Centers for Disease Control and Prevention, and we are part of a national network of STD clinical prevention training centers, or NNPTC. Here is a map of the different regions for the NNPTC, and what you can see is that the California Prevention Training Center, in addition to California, also serves Nevada, New Mexico, Arizona, and Hawaii. We participate in something called the STD Clinical Consultation Network, and that is a platform where you can submit STD questions and they will be answered by subject matter experts within the region. So to do that, you go to stdccn.org and they'll be answered either by phone or email in 2 to 5 business days per your preference. Here is our financial disclosure and a CME disclosure. For CME, those who registered on the NNPTC website and watched this webinar live and in full are eligible for CME. After this, you will be emailed an evaluation by August 4th. And so people submit a lot of questions related to this. I just want to really highlight this point that You will get an email. You can also check your spam and junk folders if you don't get it. Sometimes it'll go automatically to that. And for any CME related issues, you can get in touch with Elizabeth Olson at elizabeth.olson@ucsf.edu. Our CME provider is the University of Nevada. And once you submit your evaluation, then your CME notification comes in about 4 to 6 weeks. All right, so a couple housekeeping things and then we'll get started. Please put your microphone and speaker and videos off during the webinar. Your chat will be turned off during the webinar as well. And if you have any questions, then I encourage you to submit them, and please do that via the Q&A box. When you submit your questions in the Q&A box, you can click on the Q&A icon, and then that opens the window where you can type your question and press send. And you can submit questions up to 2 minutes up to the last 2 minutes of the webinar. And then the presenters will answer questions either directly via the chat window or at the end when we have our live Q&A session. If you have any questions related to this event or about CAPTC and our clinical programming in general, please contact our wonderful clinical program manager, Elizabeth Olson. And with that, I'm going to stop sharing this screen and I'm going to switch from the facilitator hat onto my presenter hat and pull up our presentation. Okay, so hopefully you can see my screen and I'm not spoiling too much. And let's get started. All right, so now the official presentation. So this is the California congenital syphilis update for California jail providers. No financial disclosures for any of our speakers, including myself. For the next 20 minutes or so, I'll be going over California's congenital syphilis epidemiology, as well as pathophysiology and the management of syphilis, and that includes people who are pregnant. I'm going to go pretty quickly through this, so if questions come up, again, submit them in the Q&A. After that, Laura Kovaleski will be discussing the CDPH recommendation to screen women for syphilis in adult correctional facilities, and then that will conclude with Dr. Kristin Walsh's on-the-ground experience with that. So in terms of epidemiology, I wanted to start with this slide. This is looking at both the congenital syphilis cases in California, as well as the early syphilis cases among females from 2009 to 2018. And it shouldn't come as a big surprise to you. Both of these have been increasing. And of note, what I want you to look at is that these bars, which represent the number of congenital syphilis cases over time, have been steadily increasing in parallel to the rate of early syphilis among females. And so we see this downstream effect very directly happening over time. Congenital syphilis rates by county are here. And what I want you to take a look at is that the counties affected are primarily in the Central Valley, a few in Northern California. That's considered an emerging region where we are starting to see more congenital syphilis cases pop up. So this is from 2018. But when you look at it by cases, you can see that the larger number of, the counties with the larger number of cases is a reflection of counties that have a bigger population. So while the rate of congenital syphilis is higher in the Central Valleys and the northern counties, you can also see that there are quite a number of cases in the southern counties as well. So this really does impact our entire state. Looking at rate by race and ethnicity is especially important. This is also looking at 2009 to 2018. And what I want you to notice, which is pretty clear, is that this has been increasing, particularly among infants who are born to Black mothers. It's also increasing among people who are white and people who are Hispanic. But we see the largest rise among infants born to Black birthing parents. And that gap has been widening over time. Now, getting into the pathophysiology of this, Syphilis transmission is caused by bacteria T. pallidum. You can see this picture over here, this little corkscrew pathogen. And transmission from adults is primarily via sexual contact, and that happens early in syphilis, meaning during the first year of infection, particularly when people are symptomatic, and I'll get into that in a minute. Congenitally or via the placenta and vertical transmission, that can happen at any stage, either early or late, and very, very rarely it can be transmitted via blood, but that would be via something called a blood transfusion, so not through needle sharing typically. And it isn't something we typically see in the United States. The incubation, once exposed, is 3 to 4 weeks, but that can also range from 10 days to 90 days. So it's a wide range incubation period. Now, after exposure, about 30 to 50% of people will develop primary syphilis, which is a local infection that develops into a chancre, which is a type of an ulcer. So that chancre is typically painless. There's usually just one of it, and it has these rolled edges, a clean base. So that's how you would be able to recognize what it is. But often it's in either the anal canal or the vaginal canal. And because it's painless and it's not visible, it goes unrecognized. Sometimes you'll also have a little bit of adenopathy to accompany that. That resolves on its own. So sometimes people might even see it, not think much of it, and then it resolves and they never look into it. Then in 2 to 6 weeks, people can develop what's called secondary stage syphilis. And this is when it goes from a localized infection where that chancre is to disseminating hematogenously or via the blood, and you get these more systemic infections. So you get a rash, that's the most common. It can involve the palms or the soles as well. You can have lymphadenopathy generally. So even like on the outside of the elbows, called the epitrochlear nodes, that's classic. And then you can have constitutional fluey symptoms, and you can have these specific symptoms like mucus patches, condyloma lata, patchy alopecia. I'll show you photos of these. This also resolves in 3 to 8 weeks, and then you enter what's called a latent period, which is asymptomatic. 25% of people will have a second occurrence of these secondary signs, but most of them stay latent. And if that latent syphilis goes untreated, then in 2 to 20 years, about a third of those people will go on to develop tertiary disease, which we aren't going to get into too much detail here. For latent disease, you can think of it as early latent, where we have evidence of infection within the past 12 months, and otherwise it's called late or unknown duration. All right, neurosyphilis can happen at any stage, so always look at neurosymptoms, and transmission from mother to fetus can also happen at any stage. I'm going to show you a couple pictures. Here are pictures of chancres you can see on the penis, the vulva. Here is one that has multiple on the penis. Here are some chancres on the mouth, so you know what that looks like. And here's a rash of secondary syphilis. Maculopapular, typically on the torso. Here's what it looks like on the palms and the soles, so it can affect the thick skin. And sometimes you have to do a very thorough exam and look specifically at the scrotum. Always examine the genitals when you're looking at a syphilis diagnosis. Here's some mucus patches. They can be under the tongue, on the top of the tongue, in the inside of the lip or the buccal mucosa. You want to use a flashlight to look at that. And here's what patchy alopecia looks like. So it's just a irregular patch of hair loss. And this is condyloma lata. It often is mistaken for genital warts. One way to tell is if you ask a patient, oh, did you have warts and then they went away? That's condyloma lata. If they had warts and then they went away on their own after a couple weeks. All right, for neurosyphilis, which I mentioned, that can happen at any stage. And I'm not going to go over all the details on this slide, but what I want you to know is that the early manifestations will typically involve the cranial nerves. And so you definitely want to check hearing, you want to check vision, and you want to check for specifically hearing loss, and if there's any changes in vision and visual symptoms. And any abnormalities with any neuro exam should refer a patient to, or should indicate a lumbar puncture. You should do that. You can do that. Here's a quick summary of syphilis staging. So first, is it symptomatic or not? If yes, then you distinguish between primary or secondary. If they're not symptomatic, then you need to figure out if this happened in the last year. And here are the ways to do that. First, was there a negative syphilis serology that became positive in the past year? Was there a fourfold increase in titer if this patient has had syphilis in the past, and then their titer goes from, let's say, like a 1 to 1 to 1 to 4, then that would indicate a reinfection. Also, do you have a known contact to an early case? Do you have a good history of signs or symptoms? Or the only possible exposure was this year. If you have somebody who had their first sexual encounter within the past 12 months, that would also indicate that this is an early infection. If yes, it's called early latent. If not, it's late latent or unknown duration. And then, as I mentioned before, you also check for neuro symptoms. And if you have neuro or ocular, which can accompany any of these stages, then you can diagnose neurosyphilis that way. Now, in terms of congenital syphilis, so I know that was a whirlwind, but I want to move on to mother to child transmission, since that's really what is prompting this webinar. Mother to child transmission happens vertically, so it's via the placenta, and it's associated with earlier stages, and it's associated with higher titers, and I'll get into titers soon. But essentially, the higher the burden of disease, the more likely it is that it will cross the placenta and infect the fetus. It is deadly for about a third of cases. This is a study that was done by Pablo Sanchez. He's at Children's in Ohio, Ohio Children's Hospital. He looked at almost 200 confirmed CS cases and found that the mortality was about 35%, which is quite high. And of those, about 80% or 4 out of 5 were stillbirths. And of the stillbirths, the majority happened before the 3rd trimester. So it's really important for you to, if you have pregnant patients, to make sure that you test and treat for syphilis by the 3rd trimester to decrease mortality related to congenital syphilis specifically. Prenatal treatment does reduce the risk of stillbirth. This is a study that was done by Hannah Blankow. It's a meta-analysis, and she found that if you treat according to stage of disease, you have an adjusted risk of 0.18, and that confidence interval is also impressive, 0.1 to 0.33. So it really, really reduces the risk of a stillbirth occurring. And this is a mathematical model that was done that looked at what percent of CS deaths were preventable by treating pregnant women at a specific gestational age. And what she found was that about 70% of CS stillbirths were likely avoidable if the treatment was given by 21 weeks of gestation. So within that first half of pregnancy, it really works. Now, I mentioned titers, and I want to come back to that here. Non-treponemal titers are your RPR, your VDRL. These are basically looking at antibodies that are not specific to syphilis, but they do allow for a quantitative measurement, meaning that these will increase and decrease based on syphilis infection, and they reflect the burden of disease. So what you can see in this graph, which is my favorite syphilis graph, everyone has a favorite, this is mine. It looks at the antibodies that rise and fall based on the disease stage. So what you can see is that during this primary stage on the right, the antibodies are pretty low, which makes sense because it hasn't disseminated yet hematogenously. But then in the secondary stage, the antibodies for both the non-TREP test or RPR, as well as the TREP test, which are the next slide, the antibodies really increase and they peak in the secondary stage. Now, for the non-TREP tests, whether you treat it or not, the titers will fall, but if you treat it, they'll fall much more dramatically. Sometimes they stay positive for life at a very low level, which is called a serofast reaction. But you can see the reinfection and the response to treatment is useful for these RPR or VDRL titers. The way you interpret it is a higher titer number corresponds to a higher level of antibody in the serum. Twofold change is usually within the margin of error, meaning if you give 2 labs the same blood sample, one might call it a 1 to 32, the other might call it a 1 to 64, but that's within the margin of error of a single sample, so it's fine. If you see a 4-fold change, that's less likely to occur, and so that's considered clinically significant. And titers can fluctuate, but if it stays sustained for 2 weeks, that is also the gold standard for how you say, yes, this is a titer that is consistently staying elevated. You want to compare RPRs to RPRs, VDRLs to VDRLs. So use the same serologic test for comparison. Now for TREP tests, these are the confirmatory tests. So if you have a positive RPR, the way that you confirm that that's syphilis is you do either a TPPA, an FTA-ABS, an EIA, a CIA, because these are specific to syphilis. The thing is that these will stay positive for life usually. And so it isn't going to tell you if this is a new syphilis infection or a previous syphilis infection. So it's actually not super helpful in looking at response to treatment or reinfection. And it is starting to be used as the initial test for something called a reverse screening algorithm. There's also a point of care test which uses a TREP test. So this looks like a lateral flow assay. The one that is on the market that's in this example is the syphilis health check. This only looks at TREP tests. But the good thing is you can do a result in 10 minutes. It's FDA approved, it's CLIA waived, so you can do it in the field. Last I checked, it was about $8 per test. And there are other ones that are in the pipeline. There's a few that are coming out now. Now I mentioned the algorithms. The traditional one is the one that I said when I was introducing the TREP test, where you start with your RPR, and then if it's positive, you confirm that that's due to syphilis. So that's this algorithm on the left here. If both are positive, then it's syphilis, either past or present. If it is negative, then TPP, then the syphilis is unlikely, and this would be considered a false positive or a biologic false positive. If you're doing the reverse screening algorithm, you would start with the TREP test. And the reason that you can do that is because you would start with an EIA, which is an immunoassay, an enzyme immunoassay, or a chemoluminescent immunoassay. And the reason that we would do this is because these are automated rather than done manually. So you can do batches of them. So this is good for settings where you have a high volume of patients and you have a lower morbidity of disease in general. And the reason I say that is because you can get false positives with these, but you start with this. If it's positive, then you do the RPR. And if the RPR is also positive, then you have your positive TREP, your positive non-TREP, and you have your diagnosis. If you have discordance where the RPR is negative, then rather than think, oh, this is past syphilis, you need to confirm that the EIA or CIA is actually a true positive and that this isn't a false positive. And so you confirm it with your TPPA, which is more specific. If the TPPA is positive, that confirms that the TREP test is in fact positive. But if the TPPA is negative, then you would need to consider, could this EIA be a false positive? And if there's concern for risk, then you repeat that test in 2 to 4 weeks. So these are the two algorithms. Now, obviously, there are challenges. For false negatives, you can actually have an early primary or late latent stages that have a false negativity. For primary, it's because the bacteria hasn't disseminated yet. There's also something called a prozone reaction, which is when you have an excess amount of antibodies. Essentially, the titer is so high that it overwhelms the test. You can have biological false positives, which I mentioned, where you have a positive RPR and a negative confirmatory test. If that happens, here are the possible reasons for that, and you would need to figure out why that occurred. And then discordant serology, which I also just mentioned. Okay. Now, in terms of treatment, for primary, secondary, and early latent, you want to give benzathine penicillin G, and that's 2.4 million units, 1 dose. Alternative to that, you can give doxycycline, and you would give that for 2 weeks, 100 milligrams BID. For late latent disease, where they're asymptomatic, you would want to give 3 doses, 1 week apart, ideally, but up to 9 days is acceptable. And for that, if penicillin is not an option and the patient is not pregnant, you can also do doxycycline, and that would be for 4 weeks rather than 2 weeks. Now, in pregnancy, if you have a pregnant patient, the only treatment is penicillin. And pregnant women need to be treated appropriate for their stage of infection. If you have a patient who's allergic, who's also pregnant, then you would confirm that type 1 allergy with an allergist. And then if they are in fact allergic, you would need to desensitize them. You would do that with an allergist. And then sometimes people who are treated in the second half of pregnancy would be at risk for a premature labor because of something called the Yarish-Herxheimer reaction, which is a reaction to syphilis treatment where you develop a fever. And so some people would have their treatment done on or near labor and delivery, but coordinating that should not delay treatment for this. Now, I mentioned that it's effective in preventing stillbirth. It's also effective in treating mother and baby. It's up to 98% effective. It is a slightly higher risk of treatment failure, either during that early stage of disease and later in pregnancy, meaning after 36 weeks. So you need to treat people in pregnancy within 30 days of delivery in order for the fetus to be considered adequately treated. But in general, incredibly, incredibly effective for both mother and baby. And then in terms of follow-up, and then we're almost at the transition for Clara Kovaleski. For follow-up, for primary and secondary syphilis, if they're symptomatic, bring them back in a week, confirm that their symptoms are getting better. And then you want to repeat the titers and look for that fourfold decline. For primary and secondary, you would do that at 6 and 12 months. For people who have HIV, it could take longer, so you can go out to 2 years. And for latent syphilis, you can go out to 2 years for everybody. And again, you want to see that fourfold decline. And with that, I want to announce that our expanded syphilis screening recommendations, which California Prevention Training Center developed with CDPH and the California STD HIV Controllers Association, came out December 2020. So it's available on our website. And we are doing this to highlight the syphilis screening in California jails, which is one of the strategies that we're doing to address congenital syphilis in the state. And with that, I am very privileged to introduce my colleague, Clara Kovaleski. So Lara, I will let you take it from here.
Great, thanks, Roz. Hi, everyone. So as Roz just stated, my job is to kind of summarize what you're going to find in the correctional screening section of the expanded syphilis screening guidelines. So we started each section of the guidance by outlining the relevant California codes. So in a correctional setting in California, Title 15 outlines the requirements for adult and juvenile correctional settings, including those related to delivery of medical services. For juvenile facilities, Title 15 requires a medical exam be completed within 96 hours, which includes testing for STDs in sexually active youth. National guidance recommends that this exam actually happens within 72 hours. So we often hear juvenile facilities report using that time frame as their benchmark. While adult facilities do have Title 15 requirements around receiving a health screen, the regulations do not specify that STD services must be included like they do for juvenile facilities. So this contributes to the sort of patchwork nature of STD screening programs in adult facilities. Next slide. A number of national recommending bodies have released recommendations related to screening for STIs in jails. So 2 important ones that I will highlight here are the Centers for Disease Control and Prevention, or CDC, which says that universal screening should be conducted on the basis of local area and institutional prevalence of early infectious syphilis. It also says that correctional facilities should stay apprised of syphilis prevalence as it changes over time. And then there's the National Commission on Correctional Healthcare, which released a revised position paper on this topic in 2020. And that position paper states that correctional facilities should review the yield of active syphilis screening in their institutions and local communities to determine whether screening is appropriate at intake. They also state that universal screening should be conducted on the basis of local area and institutional prevalence of early infectious syphilis, and that all pregnant women should be screened for syphilis. Next slide. And then in terms of research, so published studies showing the impact of screening on the prevention of congenital syphilis are limited. However, there were a few key studies conducted in the 1990s, which was another period in time when congenital syphilis rates were elevated. And those do support the impact of screening in this setting. So first, a study was published in 1997 outlining the impact of a protocol to provide rapid syphilis tests to everyone admitted to a New York City women's jail. And in the year studied, which was 1993, They identified 115 new infections among the 727 people that were included in the analysis. Of all the people screened, 55 were pregnant. Among these pregnant cases, 17 had indications for treatment, 15 were treated on site, 8 were actually followed through to their delivery, and in total, 7 cases of congenital syphilis were prevented. Next slide. There are also 2 important studies from this time that address the cost effectiveness of routine syphilis screening in adult corrections. So the first one was published by Silverstein et al., and it evaluated the cost effectiveness of routine rapid syphilis screening for all adults within one county jail over a 2-year period. And the conclusion was that screening was cost effective for both syphilis and congenital syphilis prevention. The authors estimated there was a 4% prevalence among people who are or could become pregnant, and that the cost break-even point would have occurred at a prevalence of just 0.15%. The second study, published by Kraut et al., used a mathematical model to assess the cost effectiveness of universal rapid syphilis screening at intake for all adults in US prisons and jails. And the study was focused on syphilis prevention only and didn't look at the additional benefit from preventing congenital syphilis. For syphilis prevention, the conclusion was that the programs would be cost advantageous if prevalence of syphilis infection surpassed 1%. And again, that's without even accounting for the additional savings from congenital syphilis prevention. Next slide. So we just heard from Dr. Plotzker about the current significant burden of congenital syphilis in California as a whole. We don't have access to data on positivity in jails across the state directly, but there are a few ways to consider what the likely burden of syphilis is among people who are or could become pregnant in this setting. So first, in 2018, nearly 1 million adults were booked into California jails, and approximately 5 to 15% of these adults were females. While syphilis prevalence in California jails is unknown, California prisons screen comprehensively on intake and reported between a 3 and 5% positivity. So if we estimate jails have a prevalence at the low end of the prison system's reported prevalence, we'd be estimating between 1,500 and 4,500 females in California jails had syphilis in 2018. And in fact, it's likely that in some counties, jail morbidity is even higher than in the prison system. In 2017 and 2018, jails in 2 different counties screened a total of almost 1,300 females, and combined, the prevalence of syphilis among females in these facilities was 9.2%. So in addition to this being higher than what we see in California prisons, this is over the 1% threshold that was described in the Kraut et al. Study as the minimum prevalence required to make universal screening cost advantageous. Next slide. Additionally, when we interview mothers of babies born with congenital syphilis about their experiences during pregnancy, we learn that many of these mothers are living in a context with really complex social determinants of health, including poverty, disparities in access to care, and stigma, to name a few. These experiences affect the prevalence of maternal risk factors for having a baby with congenital syphilis, many of which are shown in the bar graph on this slide. Importantly, over a quarter of mothers interviewed in 2018 reported a history of incarceration within the last 12 months. For these mothers, offering screening and treatment during their period of incarceration may have helped prevent a case of congenital syphilis. Next slide. So given all of this, the California Department of Public Health included a new recommendation around syphilis screening in correctional facilities in the expanded syphilis screening recommendations for the prevention of congenital syphilis. The recommendation is as follows. All people who are or could become pregnant entering an adult correctional facility located in a local health jurisdiction with high congenital syphilis morbidity should be screened for syphilis at intake or as close to intake as feasible. Next slide. We define high morbidity jurisdictions as one that has a rate that has had a rate of 8.4 congenital syphilis cases per 100,000 live births for any of the past 3 consecutive years. And you can see from the map on this slide, which I see the note is still here, but I have confirmed this is the most recent map. Most of California meets this threshold. The baseline rate of 8.4 per 100,000 live births was chosen because it reflects the national rate of congenital syphilis in 2012, which is prior to California's current period of increasing congenital syphilis rates, and the last time that California had a congenital syphilis rate below the national rate. Next slide. So before I hand this off, I do want to acknowledge some important considerations for implementing these recommendations, which is also outlined in the guidance. So first, and this goes for syphilis screening in any high morbidity setting, consider implementing screening programs using an opt-out model, where you let people know that part of routine care is to test them for syphilis, allowing them a chance to opt out of the test if they'd like. Opt-out screening programs consistently reach more people compared to an opt-in model, which relies on the accuracy of an individual's risk perception to initiate screening. Second, deploying a rapid syphilis test rather than a traditional laboratory test that may take a few days to return, and then presumptively treating anyone with a reactive result should be considered, especially in facilities with shorter lengths of stay, to reduce the number of people who are identified with an infection but released prior to receiving treatment. This strategy was used in the New York City jail protocol that informed the cost effectiveness study that I discussed before by Kraut et al. Next, we recognize the challenge of adding services during jail intake process. However, in light of the potential brevity of stay and the huge benefit of preventing a case of congenital syphilis, we recommend considering where screening can take place as close to intake as possible. Doing so will facilitate syphilis detection among a larger proportion of the people who are or could become pregnant and afford more opportunities to treat prior to release. And finally, prevention of congenital syphilis is dependent on pairing timely screening with adequate treatment according to the stage of disease. To ensure treatment is as universal as possible in the jail context, treatment should be available on site, and staff should be available and trained to administer IM medication and to coordinate medical follow-up as needed for people who are released prior to receiving their adequate therapy. Next slide. So with that, I am pleased to hand it over to our colleague, Dr. Walsh.
All right, thank you. So let me start sharing my screen. All right, so I'm Kristin Walsh. I'm one of the custody health physicians with the Santa Clara County Jail System, and I'm happy to be here today with you to talk to you about how we've attempted to expand our syphilis screening at our facility over the last 3 years. So I'll start by giving you just a little bit of background on our facility to give you some context, talk a little bit about the syphilis in our county as a whole, and then explain how we've been able to expand our screening. So to start, our jail is rather large. Annually, we book about 23,000 individuals into our facility, but I'll note that only about 8,500 of these stay for more than 72 hours. So about 2/3 of our patients cite and release out within those first 3 days. And that population becomes relevant because that became the target of our screening program as we've started. On a daily basis, our average census is around 2,100 persons per day. And of note, this is down from about 3,500 people per day pre-pandemic. So we've seen a significant drop in our custody population over the past year. And our current average length of stay for those who stay more than 72 hours is 115 days right now. Now, as far as syphilis in our county, you can see here on this graph the comparisons with the left bars being Santa Clara County as a whole, and then the bars on the right being specific to the Santa Clara County Jail. And these are concerning findings for us. So for the county as a whole, we have about 59 cases of syphilis per 100,000 from our 2018 data. But for the jail, that number was 2,800 cases per 100,000. So our jail population has 50 times the rate of syphilis compared with the county as a whole. And when we fraction this out by male and female, our female patients are very disproportionately affected specifically for the females, we have 386 times the rate of the county for syphilis in our female patients compared with females in the county as a whole. And this becomes particularly important when we think about congenital syphilis, because most of these women are of childbearing age that are here with us. Also, just to note, we do see very similar trends for other STIs. So for chlamydia, the rates for our jail are 3 times that of the county, with 9 times the rate in women. And for gonorrhea, we have 6 times the rate of the county, with 25 times the rate of the women in the jail compared with women in our county. And then lastly, looking specifically at congenital syphilis, similar to what we're seeing across the state, we're seeing our rates of congenital syphilis rise across the county. And I believe in 2020, it was 10 cases that we had. Now, as we've been looking at this and seeking to expand our screening program, in 2017, when they did interviews with the women who had children with congenital syphilis, 5 of those 7 cases reported a recent or a prior incarceration, and then 4 of 5 reported that they had a partner with a recent incarceration. And so this really drove home the point for us that we are a central place that are seeing these patients. I can, offer a personal anecdote where I had one patient I was seeing for an acute visit, offered him STI screening as part of routine health maintenance. He agreed in the clinic, and then unfortunately, when the nurse came to draw the blood later, he declined. And he fell off our radar until 6 months later, when we were notified by public health that a partner of his had had a stillbirth related to congenital syphilis. He consented to testing at that point and tested positive. And so it just really drove home how critical offering this screening is for our patients. Now, interestingly, it was these congenital syphilis links to our custody population that really was what got the final buy-in from our custody officers as we were talking about our screening program. We've been in conversations with them for years about screening, offering data. Look, we have 50 times the rate of syphilis in the county, but for a lot of our custody officers, it was really hearing that there were children that were impacted because of this that then helped us move our screening program forward. And so this is an important part of the conversation that we have. So to talk then, I'm going to share initially what our screening program used to look like before we expanded. And we never had a routine screening program before 2019. We had a single instance where we did offer routine screening to everybody in a single dorm after there were 4 genetically linked cases of syphilis that had been transmitted in custody in one particular pod. And so public health came in, offered educational talks in each of those dorms, and then we offered screening and screened 191 individuals in those housing units over a 2-day period. But beyond that, we had never routinely offered syphilis screening to every person. So the initial way people could get syphilis screening was either 1, they submitted a medical request form saying they wanted to be screened for STDs. When the nurse received that request, they would go ahead and schedule a medical visit for the patient to then see a doctor and have these tests ordered. Additionally, any patient with a chronic condition or an acute complaint that had a medical visit scheduled for some other reason, as part of that visit, our providers would then say, oh, and by the way, you're due for your STD screening. Can we go ahead and get that ordered for you now? So through both of those pathways, it did require a patient waiting for a medical appointment to be scheduled. And because that did take some time, for example, for people that only had requested STI screening, that appointment could take 4 to 6 weeks because that's a relatively low acuity appointment for us. After they waited for that appointment, they would then have the labs ordered, and it would take longer than that to then ultimately get their positive test result. And so we knew there were many missed opportunities for screening, people who had no other medical condition, no acute complaint that needed addressed, or that simply didn't think to ask for STI screening. We were missing all of those people. And that tended to be our younger population where the rates of syphilis are the highest. And then because a medical visit was required to have any of this done, we had many people get released before their appointments. Lastly, again, because of these delays in getting the appointment and then having the labs ordered and then processed, we would see people leaving before they got their results. And so we, in 2018, began talking about how we wanted to expand our screening. And so initially, we got our funding through Gilead's Focus Grant in partnership with a local nonprofit in the county called the Health Trust that has historically done HIV linkage services for the jail system. And so they felt that this was an extension of their mission. And so we partnered with them on that. And then we've continued our partnership. We're now funded indirectly through the California Department of Public Health Hepatitis C prevention and control activities. And so through that grant specifically, the grant funds a phlebotomist for a routine hepatitis C screening. The custody health system then pays for the cost of a syphilis test to be done as an add-on to those lab samples. So we're able to indirectly continue this program. We've expanded our screening then is we've now begun offering screening to any in custody for more than 72 hours. We would be able to do it at but we currently don't have the staff or the manpower to screen the additional 16,000 people that would be in our care each year with that, though it would be amazing to do that at some point in the future. So patients are offered opt-out screening. What happens is when they're in booking, a standing order set is entered on every patient by the booking nurse that then activates at 72 hours. Those lab orders then go into a specific work list just for our phlebotomist for this program, which is separate from the other phlebotomy work lists that our nurses use for other lab draws. The phlebotomist then goes and approaches the patients in their housing unit over the course of the following week to draw those labs specifically. So as a brief refresher, initially our program required a medical visit either based on a request or based on some other condition in order to get the screening. Now with our expanded screening, every person is now offered this opt-out screening, ideally within 3 to 7 days of booking. Additionally, we were able to revise our policy so that people who request STI screening no longer require a doctor's appointment. We have now a standardized procedure for nursing that when someone asks that, the labs are also automatically able to be ordered, and it cuts down that time that it takes. Our providers, lastly, still continue to offer STI screening at any visit if somebody hasn't already had it through one of the other two pathways. And because we're able to shorten this window, we're hopefully able to get to those positive results faster, though we still unfortunately lose people before the results come back. So since we have expanded our screening with our first initial funding year, which was July 2019 to July 2020, we saw a 140% increase in our rate of syphilis screening. And so we went from averaging 239 tests per month up to 574 tests per month. And so we were very proud of that increase. And with that increase in testing, we saw a 68% increase in syphilis detection. And that was based off of having a positive RPR or reactive TTPA. And so that went from 23.5 cases per month to 39.5 cases per month. Our numbers for this year during our first quarter, because of some changes that I'll talk about in a second, are a little bit lower. We're averaging about 380 tests per month with 31 cases of syphilis detected on average. So some of the trends and the changes that we've been noticing is one, there's been a decreased rate in incarceration since the pandemic started. So we have a smaller population that we're working with screen. Additionally, we've run into some challenges because of COVID. All of our patients go into a 10-day risk management unit. So everybody is housed there, from day 3 to day 7, where we historically would have been reaching them in a different housing area for the lab draw. Our phlebotomist has, reworked his schedule and is spending a large percent of his time there to capture those patients. But because there's so much else happening in that unit, for example, all of our patients that are detoxing and on detox protocols are also there. There is a lot of competition for space and for the custody staff support. And so we're not able to reach everybody in that unit. So some people's tests are happening a little bit after that initial 7-day target once they're rehoused to their final dorm. We additionally had that change in our grant funding and staffing. So there was a lag in our program at the end of last year. And so our current averages are down a little bit compared with last year for those reasons. So looking then just at our 2020 data to close things out. In 2020, we detected 162 new cases of syphilis, with 2 of those cases occurring in pregnant women. The cases that we were picking up, by and large, were latent syphilis. Almost 2/3 of them were latent, with 5% being primary and 3% being secondary. Of the almost 1/3 that would be classified as early latent syphilis, most of those were people that were frequently incarcerated, and we had several tests on them from our system, and we quickly picked up new cases, even if they were asymptomatic. We don't have any threshold to hold the lab order set. So you could be rebooked every 2 weeks and the lab order set will continue to reactivate. You have the option to opt out, but we are picking up cases where people were negative, a month ago, and now they're back with us and positive, and we've been able to treat those patients. And then lastly, I'll just mention a few of the demographics related to our cases. And so one that's quite notable, especially in this conversation around congenital syphilis, is more than 1/4 of our cases are in female patients, though less than 10% of our jail population overall is female. So our females are really disproportionately impacted by syphilis, and we have a huge opportunity here to test and then treat. When we look at race, ethnicity, admittedly, our electronic health record is a little bit odd in that it allows you to choose Hispanic as both a race and an ethnicity. And so 54% of the respondents only chose Hispanic with no other race. But overall, of everybody who chose some option for Hispanic, that's summed to 67% of our population, with whites or white Hispanic being the next largest population. And then lastly, when we look at the age, our highest percent of cases are occurring in those that are 30 to 34 years old. And so with that, I think I will end, and I will send it back to Dr. Plotzker for the Q&A.
Oh, I'm on mute. Thank you so much. All right, so we have a couple great questions. Can people hear me okay? Okay, yes? Yes, okay, I see a thumbs up. That's good. Okay, we have a couple questions. So first, a couple of them I answered, but I think it actually might be worth highlighting, and people can chime in questions. One question is, and I answered these via text, so I think everyone should be able to see this. One is, when are the new syphilis stats after 2018 going to be available? So CDPH is catching up to 2019 and 2020, as you can imagine. A lot of the epidemiologists were impacted by COVID-19 work. So we're catching up, but I put the link in the chat or in the question and answer that I think people should see. And so we're hoping the 2019 data will be up in a couple months. Slides will be available to participants. One participant asked, is 9 days apart okay for pregnant females? This is a fantastic question and a good opportunity for me to bring up the fact that the CDC released the 2021 STI treatment guidance last week. And as you can imagine, all of us were really excited. I'm not sure if this was big news in your world, it was big news in mine. And the answer to that is that now, this is an update, treating people in pregnancy, it says that missed doses greater than 9 days between doses are not acceptable for pregnant women. It used to say strict 7-day intervals, and now it says missed doses greater than 9 days. And it also says that an optimal interval is 7 days apart. So you should really, really, really strive for 7 days. The data around the pharmacokinetics of penicillin beyond 7 days is less good than what we have for 7 days specifically. And then if a pregnant woman does not return for the next dose on day 7, you have to make every effort to contact her, link her immediately for treatment within 2 days to avoid retreatment. And then if you miss a dose, you have to restart the series. So that's the long answer for that. But I encourage everybody to check out the new STI treatment guidelines, which are up online. All right. So I want to do a question for Kristin, and I just want to see if you have any insight on this. This is a question from Daniel Tran. He says, I'm curious, how many nurses phlebotomists does Santa Clara County Jail have? I would love to see opt-out testing in our county as our syphilis rates are climbing. However, in our rural community, the population is 130,000. We only have one jail for the whole county, and the staff say they are understaffed and the opt-out model would be a challenge to implement. Are there any other small counties that have a opt-out model in their jail system that has been successful with implementation? If so, I would love to hear experience from those counties. Okay, so I know that's a long, long question. Kristin, since you've had this on-the-ground experience, what advice would you give to somebody who's in a rural county who's trying to implement this? Like a more rural county, if someone redirected you there.
Yeah, I mean, you can do a lot with a little. And so targeting high risk dorms first is always a great start. I mean, we do all of this with a single phlebotomist. And so he's approaching roughly 600 people per month right now. And he's sort of managed his time each week based on being sure to hit the dorms where the most people are, and then also where the highest acceptance rates are. And so it's working that way. So for example, if you wanted to start with women, just start on the women's side and then slowly expand, similar to how we did did a single day testing in the one unit where we knew there were in custody transmissions of syphilis happening. We were able to make it happen there. But it can be hard. The other thing that it can be easier to add on is if people are already having labs drawn for something else, having a standing order set where this automatically then populates into the lab orders. The nurse is already there drawing the labs for some other medical reason, and you can at least begin expanding screening that way, even without hiring new staff.
Okay, thank you. So Daniel, I hope that's helpful, but Q&A is still open if you want to chime in and add a follow-up question, but I think that sounds good. Another question for Dr. Walsh, and I apologize if you mentioned this, but there's some curiosity about which rapid syphilis test was used in the.
We don't use rapid syphilis tests.
Okay.
It's all a reverse test.
Okay. I don't think it was rapid, but okay. So the rapid syphilis test, this was not an attendee, but the rapid syphilis test I discussed is called, it's called Syphilis Biocheck. And it is 10 minutes to the result time. So that's one. All right, let's see, what other questions are there? There's one question that says, can you get a false positive TPPA? The answer is yes, you can. It's rare. I don't have the specific stat off the top of my head, but I'm happy to look that up. There is a study, if you're interested. This is for Toa No. There's a study that was written by Ina Park, who's actually our medical director, coincidentally. But she did a really nice assessment looking at the sensitivity and specificity of different syphilis tests. So I would encourage you to look that up if you go to Google Scholar and then you look up Ina Park syphilis testing. You can see the sensitivity and specificity for that. But in general, TPPAs are, it's rare that you would have a false positive. All right, one question. This is also a clinical question. What is the treatment option for a pregnant patient who is allergic to penicillin after the severe allergy is confirmed by the allergy specialist? And the answer is the only option is penicillin. The way that this works is when you confirm that there's a severe allergy, the patient has to undergo something called desensitization, which essentially is when you have the patient, this is done typically in a hospital with an allergist, and you give incremental, very, 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 very small doses of penicillin, and you desensitize them. And then you can give the penicillin treatment. So if that ever comes up, it is something you have to coordinate. It does take some planning, but that really is the only treatment option, but it's worth it compared to no treatment. So I hope that that's helpful. All right, let's see. Going through some questions. All right, this question is, okay, oh, we're having some more questions pop in, great. All right, so this question, has the increase in positive test and treatment impacted your provider workload? So this is also a question for Dr. Walsh. How did you help mitigate that, if yes? And are there any policies around a standard protocol for treatment? Or do you bring patients into clinic to decide stage of syphilis and then decide treatment? Thanks. So I think that this is from Solma Herrera. So Solma, it sounds like you're interested in basically how to streamline this so that it is minimally impacting the provider workload.
So to answer that, it's a lot of work. It takes some time. I have a little bit of extra admin time to help handle this rather than direct clinical time. There's no standard procedure for just how to treat. And so every positive case requires a chart review to look to see, do we have any old titers, to know if this is, early latent or late latent. We review nursing notes to see if they complained of some sort of genital ulcer or rash that might suggest primary or secondary syphilis. We'll go into this shared system called Care Everywhere for the other healthcare facilities in the county. And if we still can't find anything and it's somewhat murky, we'll email our CDIs from public health and say, hey, do you have any old history in the state on this person? For example, if their titer is 1 to 1 and you have no idea if it's a new rising titer, if it's an old senescent titer, if it's a serofast titer. And public health usually gets back to us the same day. And then if we are not sure, we treat with 3 doses of penicillin every time, unless we can prove it's something other than that.
All right, so I've gotten a couple follow-up questions about penicillin allergies and desensitization. So what I'm going to do actually is I'm going to put this in the chat, but essentially for desensitization, there are different protocols for desensitization, and when you do desensitization, it kind of depends on how you do it. If you need to do it every single time you provide the penicillin, if you have a 3-dose regimen, or if you do desensitization and you have to do it with each dose. So I'm gonna it's a little complicated. And what I'm going to do is I'll put this link in the answer and as a type answer to the people who asked that. And I think you all should be able to see that. But the CDC STI treatment guidelines have a very good section on this. So I'm going to send those. But once you desensitize someone to penicillin, this doesn't last forever. So to answer one question, you do the desensitization as part of the treatment, but then a year from then, you would still have the person be allergic to penicillin. So it isn't like a complete ending to it. All right, so one question, let's see, we've got a couple more. Okay, one question that's kind of interesting. This is from Irene. Irene, I think you pronounce your last name Sumi. What if you treat a pregnant female earlier than the 7 to 9 days recommended? So this is a good question. In California, before the 9 days, before it was okay to go up to 9 days. So in other words, before the CDC updated guidance was released, it said strict 7 days. And CDPH reviewed all of the data that was underlying that 7-day interval and basically said, we are willing to accept 24 hours before and after, meaning we are willing to accept 6 days and 8-day intervals as well. And that's also based on a study that was done with some of the cases that had that interval to look and compare outcomes. So in California, at least as of now, we are still willing to accept 6 days as an acceptable interval. And for people who are pregnant, pharmacokinetics are not very well described. So I would think 5 days is cutting it kind of short. So I would not personally feel comfortable saying okay to the 5-day interval. And just to give everybody a little bit of an idea of where these intervals come from in general, to geek out for 1 minute, penicillin efficacy for late latent disease is based on the need to have a certain threshold of concentration for 21 days sustained. So in non-pregnant patients, it's been demonstrated that a single dose of penicillin will maintain that threshold for 7 days, possibly more. And so we say, okay, if we do 3 doses that are 7 days apart, then each dose is 1 week long, and that gives us our 21-day sustained interval, right? What we don't know is that in pregnancy, after 7 days, does it dip below that concentration? And that's something that we just don't have a lot of data to say one way or the other. So that's why we want to say, like, okay, we want to maintain this threshold for 21 days uninterrupted. So we're going to do these 3 doses 7 days apart. Now, based on some clinical experience that we've had over the past decades, we are starting to see that, if we go 8 days, it's probably okay. 9 days, getting close, but also probably okay. But beyond 9 days is really, we don't know. We don't have any data. And so we don't want to go beyond a 9-day interval. So it's really about how long the penicillin stays in the blood at the level we want, which is why it's a hard question to answer and why it's a good question to ask. So I hope that's helpful, even though it's inconclusive. All right, so we're going to move on from that. We've got another 5 minutes or so left. All right, what about, let's see. All right, here's a question, anonymous, which is a great question for Dr. Walsh. What is your relationship like with your local DIS? Do they come into the jail and do interviews of the positive cases? So yeah, how do you handle this? I know that you and Dr. Rudman have a good relationship. So how does this work with disease investigators?
Yeah, so we love our disease investigators. They we contact them primarily through email. Pre-pandemic, for concerning cases where they needed to do contact tracing, they would come in person. Now it's primarily telemedicine visits that they will set up via our nurses if they need to do a more extensive patient interview. And then if it's just data we need, like, do they have old titers or treatment history from somewhere? They just send us that information from CalReady via email.
Okay. All right. Thank you. All right. Quick question. Is rapid syphilis testing covered? And so I think that this, I think that with rapid syphilis testing, I would imagine it would be covered just because it's I would imagine it would be covered because it's a TREP test. And so you would probably bill it similarly to that. But I would also check with, I would probably check with either the medical billers who you work with, or if you have a contact who works with Medi-Cal at your county, you could check with them. Lara Kovaleski, if you're still there, I don't know if you might know the answer to this one. It's a good question.
I'm not sure.
Okay.
But look into that maybe and send it with the follow-up. I mean, in most cases, folks who are incarcerated are not receiving, they're not being, their services are not being billed for. So in this context, it probably, I can't really imagine a scenario where it would be covered. But outside of a correctional setting, it's a good thing just to confirm. So we can look into that.
Okay, great. Thank you, though. It's a good question. It's always a good question if we don't know the answer. All right. Okay, so another question from Anonymous, which is, I'm assuming Anonymous people are not all just one person. So this one says, talking about the worst case of syphilis on a pregnant woman who was successfully treated for syphilis while pregnant. If the baby has sustained damage from syphilis, what are the medical conditions / diagnosis of those babies, and how bad are the baby's conditions that were reported? So that's a really interesting question. And now we're getting outside of, screening in jails and more onto the clinical congenital syphilis itself piece. And, like I said, in my portion of the lecture, congenital syphilis is fatal. So I would say the worst case scenario, the worst outcome is a pregnancy loss, and that can happen. Otherwise, if you have somebody who was successfully treated, you're right that there is a small proportion of cases where that doesn't result in successful treatment. And so now you're getting into questions about what happens in congenital syphilis. We actually at the CAPTC website have a really good webinar on this, CR website, with our STI fellow, Kelly Johnson, as well as a pediatric infectious disease doctor, Niall Mason, who's down at Valley Children's. So what I can tell you just briefly is that there's a wide range of abnormalities that result from congenital syphilis and congenital infection. There are early manifestations that happen within the first 2 years of life. And these are things that are related to organ development, neuro involvement. You can have ocular findings and things like that. So you can have hepatomegaly, splenomegaly. And then there are later manifestations that happen 2 years after, 2 years or beyond. And those are typically more skeletal, and they can also involve the nervous system. And they are, you can think of those as responses to the early manifestations. So the early manifestations are more active infections that are ongoing. Sometimes you have lesions that are infectious. And then the later manifestations have to do with the scarring and stigmata from that. And so that's where you get like saber shins, Clutton joints, and teeth abnormalities, things like that. But it's a really interesting thing to look into, and I would encourage you to watch that webinar. All right, so we have 2 more questions, and I'm going to have to cap it at that. Oh, 3 more questions. So quickly from people who haven't asked yet, for partner treatment, is there any time frame for treat partners of a patient diagnosed with primary, secondary, early and late latent syphilis? So typically, yeah, so the answer is yes. And you want to go, you want to treat your partners as soon as possible. So I would say that for early syphilis, I would have to look at the interval. I don't want to say the wrong thing, but I think it's within the past 2 months. It might be in the past 3 months, any partner within the past 3 months. But it's in the CDC treatment guidelines. So I would suggest that you look at that. That's for Florencia. And then if a mother misses her second or third penicillin injection, the day 9 closing schedule, and she is diagnosed with late latent, how would you proceed in restarting the treatment? So in that case, you want to restart as soon as possible, and explain clearly that this person needs all 3 doses, which is sometimes not an easy conversation to have with someone, that they have to start all over, but you can also emphasize that the importance is to have them every 7 to 9 days. And if it goes beyond that, then the treatment won't work. So work with them and figure out how to accomplish that in a way that works for them. Okay, and so I think that wraps it up, and we're also at 1:15. Let me just pull up a couple final slides to say goodbye, which is just our resources that I'd like you to be aware of. And then, okay, so there we go. There's my slide set. And so let me just go through a couple quick resources. If you can see here. All right. And so here is our guidance. Oh geez. All right, let's scroll through these really quick. Sorry about this. All right, so we have a pocket card. This is a CDC syphilis pocket guide. As I mentioned, there are these STD CCN, submit your things, and I want to say thank you very much to everybody, and also acknowledge my colleagues who contributed to this. And we've gone over questions. So with that, thank you all so much, and I hope you have a great end of your day.